Welcome to my session on online surgery class. Today's topic is on peripheral arterial disease. Now, peripheral arterial disease, there's got two parts to it. The first part is the chronic limb ischemia. And the second part is your acute limb ischemia. Okay, although both are related, but the presentation are very different, especially the acute. The presentation is very acute. Okay, so we shall discuss these topics in briefly, go through the causes, the clinical signs and symptoms, and also the investigations and management of this condition.
Okay, I will begin with part one, in which we'll talk about chronic limb ischemia or CLI. Okay, chronic limb ischemia is a form of peripheral arterial disease that results in symptoms due to reduced blood supply to the limb. Okay, it is typically caused by atherosclerosis, rarely by vasculitis. Most common is atherosclerosis and will commonly affect the lower limbs, most commonly lower limbs. However, the upper limbs and gluteal region can also be affected. Around 15 to 20% of individuals over 70 years of age have peripheral arterial disease, although the majority are asymptomatic. The Framingham study reveals the increase in prevalence of the disease from 0.4 per 1,000 males aged between 35 to 45 years. This increases to 6% per 1,000 males when they reach more than 65 years. In this lecture, we shall look at the clinical features, investigations, and management of chronic limb ischemia. Now, what are the risk factors for this disease, peripheral vascular disease? The risk factors basically are smoking, diabetic, hypertension, and history of hypercholesterolemia, associated with atrial fibrillation, ischemic heart disease, or cardiovascular accidents. So, this in summary. Okay, so these are the important symptoms. These are the important risk factors: age, okay, the leg symptoms, abnormal lower extremity pulsation, and a known case of atherosclerosis. Okay, so to summarize the main risk factors of chronic limb ischemia: atherosclerosis main cause, smoking, diabetes mellitus, hypertension, hyperlipidemia, increasing age, strong family history, and another important one is obesity with physical inactivity. Now, what are the clinical features of chronic limb ischemia? Okay, depends on the earlier symptoms of chronic limb ischemia is intermittent claudication, which is a cramping type of pain in the calf, thigh, or buttocks after walking a fixed distance, which is referred to as the claudication distance. And this pain is relieved by rest within minutes. Okay, so as the disease progresses, the pain becomes constant. Even at rest, the pain is felt. And at this stage, it is known as critical limb or critical limb threatening ischemia. Okay, these are the various stages of the disease and severity by the Fontaine classification for chronic leg ischemia. Stage 1 is asymptomatic. Stage 4 is ulceration or gangrene or both. Okay, so this is the most severe form. Stage 1 is asymptomatic. Stage 2 is intermittent claudication. It's the stage where the patient develops pain on walking or exertion. And stage 3, he gets rest pain, ischemic pain even at rest. Okay, so this is a progressive type of symptoms from stage 1 to stage 4. So patient asymptomatic becomes intermittent claudication. and this claudication becomes worse. Okay, the distance becomes less. Then patient develops stress pain, with the pain even at rest, especially at night. And then later, this can lead to critical limb-threatening ischemia. On examination, what you get in this patient, the affected limb is colder than the unaffected limb. The arterial ulcers may be present, especially in advanced cases. There may be distal peripheral ulcers, reduced or absent peripheral pulse, femoral brie, if there's a blockage or narrowing of the femoral arteries. Okay, this is due to advanced cases. Can be due to femoral stenosis. And the Burgess test, okay, may become positive. This is the adequacy of the arterial supply to the leg. Okay. This test involves lying the patient supine and raising the leg until it goes pale. Normally, they raise it until 45 degrees. Then lowering them until the color returns or becoming hyperemic. The angle at which the limb goes pale is termed Burgess angle. The angle of less than 20 degrees indicates severe ischemia. So this is a Burgess test, which can be done to assess to confirm the presence of ischemia and also to assess the severity of the ischemia. Now, how do you classify the peripheral arterial disease? Okay, this is a simple classification by Rutherford and Fontaine. Two classifications normally used. Basically, it classifies the patient into three main categories: asymptomatic. Okay, here also asymptomatic. Then is the symptoms of claudication. Here, the second stage is the claudication symptoms, where the patient develops pain on walking. Then, as the disease progresses, then the claudication becomes more severe until it develops rest pain. Okay, even at rest, the patient gets pain. And lastly, the most severe form is when there's tissue loss, there's ulceration or gangrene, where ulceration and gangrene sets in with sepsis. So this is the most severe form. So basically, 4 stages, as I mentioned in my earlier slide. Okay, these are some pictures showing you this here already having gangrene or ischemic changes here. There is an ulcer, peripheral ulceration on the foot, and here you can see pallor. Okay, this is pale, cause of poor blood supply, and here is a normal limb, so pallor. Okay, these are known as trophic signs. Okay, the skin becomes shiny. Okay, there's loss of hair, the nails become brittle. Okay, there's pallor, and there may be also ulcers. Next is so this is the trophic changes that are seen: shiny skin, hairless, tapering, brittle nails, and weak pulse. This is ulceration. Okay, so you can see here ulceration, distal ulceration, these two ischemic changes. Okay, these are known as arterial ulcers, and they are red in color due to inflammation, or maybe black due to gangrene. Deep wounds, okay, they are punch-out ulcers. Can you see? They are punch-out ulcers, deep wound, deep ulcers. Tight, hairless skin, okay, as shown here, the hairless skin here. The toes are tapering. The leg pain at night, usually they have pain even at rest, especially even at night, which prevents the patient's sleep. No bleeding. Rarely there's bleeding because there's not much blood supply. Affected area is cold and maybe clammy. Leg ulcers redens when the tangled and turns pale when elevated. This will be the just sign. Okay, so this pictures summarizes the clinical features of chronic arterial disease. Okay, now I describe to you what is the Burgess test. Burgess test, patient is lying supine, raise the foot and leg to 45 degrees or less, watch the leg becoming pale. Ask the patient to sit up and hang the leg at the foot end of the bed. Legs become blue, then red. It's a positive test. Okay, hyperemic. hyperactive hyperemia. Okay, here the leg is elevated to about maximum 45 degrees, so the leg becomes pale, the foot becomes pale. Angle at which the limb goes pale is known as the Burgess angle. How many degrees from the horizontal? Here, when you after that ask the patient to hang the leg down, and then the leg becomes straight. Okay, hyperactive hyperemia, rubor, pallor and rubor. Okay, so these are the signs here. Pallor here, elevation of leg, then you hang the leg, becomes straight. Okay, same thing. Pallor, when you elevate the leg, then becomes pale, and when you hang down, becomes hyperactive uh, hyperemia.
Berger's test is an important test in physical examination and clinical research, which is used to assess the adequacy of arterial supply to the legs. Examination sequence: with the patient lying supine, stand at the foot of the bed. Watch for pallor with emptying and guttering of the superficial veins. Ask the patient to sit up and hang their legs over the edge of the bed. Watch for reactive hyperemia on dependency. The loss of pallor initially and spreading redness make a positive test.
There's another special syndrome known as the Larry-K syndrome, which is due to obstruction of the bifurcation of the aorta into the iliac arteries here, as shown here. Aorta, right and left iliac arteries. There's a blockage here, narrowing due to atherosclerosis. And Larry-K syndrome is a form of peripheral artery disease affecting the aortic bifurcation. The severe stenosis affecting the distal abdominal aorta, iliac arteries, and femoral-popliteal vessels. It is specifically present with the triad symptoms, triad, which is pain in the buttocks or thigh, which is claudication pain, erectile dysfunction or impotence, and absence of femoral pulse. Okay, here you can see the obstruction here. Okay, next we come to critical limb threatening ischemia. Critical limb threatening ischemia is the advanced form of chronic limb ischemia. It can be clinically defined in three ways. First, ischemic rest pain for more than 2 weeks, requiring opiate analgesics. That means he's in pain, severe pain for some time. The presence of ischemic lesions, such as ulcers or gangrene, objectively attributable to the arterial occlusive disease. And thirdly, the ankle brachial pressure index less than 0.5. On examination, the limbs may be pale, cold, and weak or absent with absent pulses. Other signs of this patient include chronic limb ischemic signs such as hair loss, skin changes such as trophic skin, ulceration, or gangrene, and thickened nails and trophic changes. These are the called trophic changes of chronic limb ischemia. Okay, critical limb threatening ischemia. On examination, the limbs will be pale and cold, weak or absent pulses, and other signs include loss of skin, hair loss, skin changes, smooth skin, atrophic skin, ulceration, gangrene. In this patient, there's massive gangrene of the toes here associated with skin changes as well as thickened nails here. Okay, very severe trophic changes. The differential diagnosis for chronic limb ischemia. There are two major differential diagnoses for a patient presenting with limb ischemic symptoms. First, spinal stenosis, acute limb ischemia, deep vein thrombosis, thrombophlebitis, and trauma. Okay, these are the differential diagnoses. In spinal stenosis, which is also known as neurogenic claudication, typically the pain is from the back radiating down the lateral aspect of the leg in the area of the tensor fascia lata. Often, they have symptoms on initial movement or symptoms that are relieved by sitting rather than on standing. The rare causes of non-atherosclerotic lower limb ischemia include popliteal artery entrapment, persistent sciatic artery, ileal endofibrosis, cystic adventitious disease, and Buerger's disease. Now, what are the investigations that are required for these patients with chronic limb ischemia? The diagnosis of chronic limb ischemia is basically clinical. I must remember this, but sometimes certain tests have to be done in order to confirm and establish the severity of the disease. Okay, and this the most important examination that can be done is a systolic pressure ankle brachial pressure index, ABPI. Okay, which is the ratio of the systolic pressure at the ankle to the systolic pressure at the brachial artery in the elbow. Okay, the severity is rated like this. Normal, the ABPI will be more than 0.9 to 1.1. Mild disease will be 0.8 to 0.9. Moderate is 0.5 to 0.8, and severe disease is less than 0.5. If ABPI of more than 1.2 should be taken with caution, as it may be a false positive due to artery rigidity due to calcification of the artery. It's important to remember that the API value of more than 1.2 should be interpreted with caution, as calcification and hardening of the arteries may cause a falsely high ABPI.
So now I'm going to do an ankle brachial pressure index. This starts by taking the systolic blood pressure in both of the arms and using the highest of those numbers, then attaching a simple manual sphygmomanometer to the lower leg and using an arterial Doppler scanner. Start by locating a pulse. Pump up the sphygmomanometer to above the systolic pressure and then gently release that pressure, listening out for that first blush of flow. And then repeat that multiple times by this. So again, around the 140 mark. Okay, then to calculate the pressure, just simply divide the pressure in the foot, which is the highest of the two numbers, by the highest of the pressures in the arms.
Okay, what are the other special investigations that can be done for these patients or should be done? First is your Doppler ultrasound, which is used to assess the severity and anatomical location of any occlusion should be undertaken. So very important to do a Doppler. All patients must be subjected to a Doppler ultrasound to assess the site of the obstruction, presence of obstruction, and the severity of the obstruction. Next one is your CT angiogram, CTA, which is very, very important in patients who may want to be deciding whether you want to go for surgery or otherwise. And the other one is your magnetic resonance angiography. It's becoming more popular these days, MRA.
Now, due to the concurrent cardiovascular risk factors seen in patients with chronic limb ischemia or chronic limb threatening ischemia, patients should also have a cardiovascular risk assessment. These include pressure, blood glucose, lipid profile, and ECG. A full cardiovascular assessment of the patient should also be done. In addition, any patient presenting with chronic limb threatening ischemia who are less than 50 years of age without significant risk factors should also have a thrombophilia screening and homocysteine levels checked. Okay, this is for patients who are less than 50 years old, have got no cardiovascular risk, no other risk factors. So the homocysteine levels should be also be checked. And this lower homocysteine level has been associated with reduced risk of cardiovascular defects. So very important. So patients, old patients, you must assess the full cardiovascular screening. Younger patients, you must also do a homocysteine levels. Now we come to the final part, the management of these patients. There are two, medical management and surgical management. Most patients with chronic limb ischemia require cardiovascular risk factor modification, assessment and modification, which I mentioned just now. Lifestyle advice, smoking, stoppage of smoking, very strict, regular exercise, and weight reduction. These are all very important. Statin therapy, ideally atorvastatin, 80 milligrams daily, is very, very useful to reduce the lipid levels. Antiplatelet therapy, ideally you use clopidogrel, 75 milligrams per day. And some patients use other forms, milder forms of blood thinning, such as aspirin, which is cardioprin, which is 100 milligrams daily. And very important for you to optimize the control of your diabetes. Very, very important. If the patient is diabetic and hypertensive, this must be controlled. And this patient should always be enrolled in some form of exercise program to improve their walking distance and claudication distance. And should be used as the first-line therapy in any patient with critical limb ischemia. All patients with critical limb ischemia or even in mild forms of limb ischemia, they must improve with exercise, and also the claudication distance must improve. So patients walking is a very, very important exercise. The cause of chronic limb ischemia is variable, and most patients' symptoms do improve on lifestyle changes and medical management alone. Most of the patients will improve to some extent. Okay, it is important to encourage this patient to walk through the pain to encourage the development of new blood vessels. Exercises develop or new collateral circulation to establish new blood vessels, which establish a new collateral circulation, which will improve the circulation from the limbs. Okay, now what are the surgical management that is available for these patients? Okay, first, when do you refer the surgery? When do you consider surgical management? Okay, two main conditions. One is failed medical treatment. When all this controlling of the risk factors and all the conservative measures that you have mentioned just now, if all of and the medications and fail, then you have to consider the patient for failed treatment. Or if the patient's condition becomes worsens from chronic limb ischemia develops critical limb ischemia, then you need surgical intervention urgently. Okay, so this will be the two main indications. So the by far most common is your failed medical treatment. There are number of methods of surgical options for these patients. First is that the traditionally used is the endoscopic thrombolysis and endarterectomy, which is giving way to the newer methods, angioplasty with or without stenting. And if this fails, then you go for bypass grafting. Okay, bypass grafting, especially if the disease is more diffuse and in younger patients. Of course, failing all this, if the patient develops severe infection, gangrene, then there's no choice. Then you have to go for some form of amputation. Okay, this is angioplasty. Okay, this is the cross section of the artery here. Okay, this is the plaque here. Okay, causing atherosclerotic plaque, narrowing of the lumen. So you introduce a stent here, and this stent endoscopically, and this will then dilate the artery, steno's part, and thereby improving the blood flow. And sometimes you also can do endarterectomy or thrombolysis through this method, angioplasty method itself. Okay, here's your compressed plaque here. So as a result, the blood can go off flat. Here, this is the artery bypass. Okay, take for example, this is the lower limb. There's a block here in the femoral artery. Okay, there's a block in the femoral artery here. So what happens? You bypass the artery. Use a graft. You bypass from before the block to after the block. So this is known as an artery bypass graft or stent. Okay, so this is for diffuse disease, and in younger patients, this will be useful. For isolated blockages, then this may be useful in this patient. Okay, what are the complications, outcome, and prognosis of chronic limb ischemia? Okay, chronic limb ischemia can develop secondary sepsis. Okay, especially in patients with ulcer and gangrene, and this can lead to septicemia and death. Can lead to acute on chronic ischemia, which will be talked in the next lecture. Can lead to amputation of the limb and reduce mobility and quality of life in patients, especially if the patients are young. Over a 5-year period, the intermittent claudication, what happens? What's the future of these patients? Most of them with stable claudication will improve. Okay. However, 10 to 20% of them develop worsening symptoms. From claudication, they may go into limb ischemia, chronic or what do you call acute limb ischemia. Okay, that's another thing. And 5 to 10% develop critical limb ischemia. 2 years following the below knee amputation for patients with chronic limb ischemia, what happened? 15% of them require further above knee amputation. 30% of them died, and only 40% have full mobility. So the full mobility is only 40% in the majority of patients. The 5-year mortality rate for those diagnosed with chronic limb disease is around 50%. It's not only from the limb ischemia, it can be from other cardiac events. Amputation is eventually required in 1 to 2% of all cases with chronic limb ischemia. And this figure is higher, 5% in patients with diabetes. Now, finally, the key points. What are the 4 key points to take back? Chronic limb ischemia is a common condition ranging from severity across the population. It is associated with several cardiovascular risk factors. While clinical diagnosis, it can be it's a clinical diagnosis, it can be quantified by ABP, ankle brachial pressure index testing, followed by imaging. And this imaging include angioplasty and Doppler ultrasound and CT scanning, CT angiogram. Surgical intervention can be offered if conservative management fails, or for those who presenting with critical limb threatening ischemia. Okay, two conditions. Medical failure treatment fails, and if he develops worsening condition, going on to the critical limb threatening ischemia. The 5-year mortality rate for those diagnosed with chronic limb ischemia is around 50%.
Okay, now we come to the second part of this talk on peripheral artery disease, PAD, which is acute limb ischemia, okay, ALI.
Okay, acute limb ischemia. What is acute limb ischemia? Acute limb ischemia is defined as the sudden decrease in limb perfusion that threatens the viability of the limb. Complete or even partial occlusion of the arterial supply to a limb can lead to rapid ischemia and poor functional outcomes within hours. Changes can come within hours. Acute limb ischemia has an incidence of around 1.5 per 10,000 persons per year. In this lecture, we shall look at the causes, clinical features, and management of a patient with acute limb ischemia. Okay, next we go to the etiology, the causes of acute limb ischemia. This can be classified into three main groups: embolization, thrombosis, and trauma. So these are the three main group of causes that lead to acute limb ischemia, of which embolism is the most common, whereby a thrombus from a proximal source travels distally to occlude the artery, which is the most common cause. As the artery becomes more distal, smaller, the lumen becomes smaller, so thrombus can block the distal branch of an artery. The original thrombus source may be as a result of atrial fibrillation. These are the common causes. Post-MI mural thrombosis, abdominal aortic aneurysm, the most common surgical cause, and prostatic valve diseases, prostatic heart valves. So these are the original thrombus come from. Second is thrombosis in situ, whereby an atheroma plug in the artery ruptures and a thrombus forms on the plug's cap, presenting as an acute or acute on chronic acute ischemia. Okay, so this is another important cause. The third one is trauma, which is less common, including compartment syndrome. This occurs in patients with the limbs where are injury, orthopedic injury, and they can develop compartment syndrome. So this is and this leads to acute limb ischemia as well. Now, what are the clinical features of acute limb ischemia? Classically, the signs and symptoms of acute limb ischemia can be described using the 6 P's. The first 3 P's here being the most common initial symptoms. Okay, the first 3, you've got common initial symptoms: pain, pallor, and pulselessness. No pulse, no absence of pulses. These are the 3 common features of that initially occur with acute limb ischemia. The others include paresthesia, perishably cold, very cold and clammy, and paralysis, loss of function. These are late complications which are less common. So most of the time the patients will present in these initial complaints where a diagnosis has to be made for immediate action. Here the picture shows you the various 6 P's: pain, paralysis, pulselessness. Okay, this is very important. Then the other 3 will be paresthesia, patient has got sensory abnormalities; pallor, the limb becomes pale; and very cold, perishably cold. Okay, this is very important. See the 6 P's you must remember. Now, the classification and severity of acute limb ischemia, and the best classification is the one called Rutherford classification. Okay, here this we have gone through in the chronic limb ischemia is similar. You got category 1 to 3. 1 is viable, okay, no problem, no immediate threat, no sensory loss, no motor deficit, arterial Doppler pulse is audible, and venous Doppler is also audible. Okay, blood flow. Here the 2 can be A or B. 2A is salvageable, that can be cured if promptly treated. Okay, minimal dose or none. Okay, sensory loss usually minimal, motor deficit usually none, and arterial is inaudible, but the venous flow is audible. Okay, 2B is slightly more severe, and in this case is salvageable if immediately revascularized. If this is promptly revascularized, yes, immediately, very fast, within hours must be doing it. Here, there is more sensory loss, and there's rest pain. There's mild to moderate motor deficit. There's loss of function of the limb. Arterial Doppler is inaudible, whereas venous flow is audible. Flow is still there. And the last group is your irreversible. The major tissue loss and permanent nerve damage is inevitable. So nothing much can you do. It's unsalvageable. So there's profound sensory loss. Motor deficit is profound, paralysis. Arterial Doppler inaudible, venous Doppler inaudible. So the whole limb is dead beyond the block. Okay, so these are the 4 categories that you must be able to remember and assess the patient to put them in which category. Differential diagnosis for acute limb ischemia include first critical limb ischemia, limb threatening ischemia, which we have discussed earlier. That's the most important differential diagnosis to recognize before treatment is immediately administered. Second one is acute DVT. Okay, this can present as 2 forms, phlegmasia cerula dolens or phlegmasia alba dolens. These are the 2 phases of presentation of development of ischemia in a patient with acute DVT due to severe pressure on the limb. And the third one is spinal cord or peripheral nerve compression. This is another condition. Okay, so these are the 3 major differential diagnoses for acute limb ischemia. Now, the investigations, routine blood tests, very important. In these patients, you must make sure you do a serum lactate to assess the level of ischemia. Okay, if the lactate is high, that means it's acidosis. That means there's a lot of muscular ischemia and muscle death. It's not so good sign. Next one is thrombophilia screen. If less than the patients are young, if less than 50 years old with no known risk factors, and it comes with the acute limb ischemia, okay, you must be able to do a full thrombophilia screening test to make sure what category this patient lies. And this patient should also be group and cross-match blood in reserve for possible transfusion. Other investigations include workout of the heart, especially ECG or echo. Doppler ultrasound scan is very, very important and must be done immediately. Suspected cases should be initially investigated with bedside Doppler ultrasound scan. Both the limbs you must do. And CT angiogram, if the limb is considered to be salvageable, that means stage 1 and stage 2, a CT arteriogram can provide more information regarding the anatomical location of the occlusion and can help decide the operative approach, such as femoral versus popliteal incision. And nowadays, MRI angiogram is also becoming more popular. Okay, in the routine blood test here, very important, you must be thrombophilia screen test for inherited deficiencies of naturally occurring anticoagulants. So this is very important. That's why the thrombophilia screen is very important. Okay, you should be also look for antithrombin, protein C, and protein S. Okay, this is a normal arteriogram of a lower limb in a patient. This is you see the aorta dividing into the right and left. Okay, right and left iliac arteries, and then femoral arteries as it goes down here. Okay, this is normal, normal flow. Here with contrast, you see here normal arteries in the lower limb. In this patient, there's a 3D CT angiogram reconstructed. Okay, showing complete occlusion of the right femoral artery. Okay, this is the aorta here, then coming here, the femoral artery here. And this side, you see the femoral artery is patent, flowing very well. Here, there's an acute or abrupt occlusion of the right femoral artery. Now, what are the management of these patients with acute limb ischemia? Okay, it can be classified again, depend on 1, 2, 3, 2B or 3. in which category the patient comes in. So the initial management, regardless of which category the patient come in, is the surgical emergency. It is a surgical emergency. Complete arterial occlusion will lead to irreversible tissue damage, muscle death within 6 hours. So early senior surgical support is very vital. So this patient should be started on high oxygen flow and ensure adequate venous access. This is very important. Hydrate them well. A therapeutic dose of heparin or an intravenous heparin infusion should be also initiated as soon as possible. Okay, so it's a surgical emergency, must be tackled within hours, high flow oxygen, and also IV fluids as well as heparin infusion. Then you get the conservative management consists of in patients with Rutherford 1 and 2A. As I said here, 1 and 2A, they are salvageable. Okay, so this is very important for you to classify the patient into whichever category the patient falls. Okay, so conservative management can be considered for those patients with Rutherford 1 and 2A. A prolonged course of heparin may be the most effective non-operative management of acute limb ischemia. Okay, so these patients which we started on heparin infusion. Okay, prolonged long-term heparin infusion, and this point, as you do that, these patients must be monitored for the progression of the ischemia. Any patient started on conservative management via heparin with regular assessment to determine the effectiveness through monitoring the APPT ratio blood test and clinical reviews. Okay, so this is a coagulation profile and your clinical review. See the viability, is it improving or not, the Rutherford status. Surgical intervention may be warranted if no improvement is seen. So anytime you see the patient is not improving or is becoming worse, then surgical intervention should be instituted without delay. And what are the surgical intervention? This surgical intervention is mandatory for patients with Rutherford 2B, 2B here, salvageable and immediately revascularized. Okay, this is this patient category. This is consists of embolectomy using a Fogarty catheter. This can be done over a wire using under radiological guidance. Okay, and this can be combined with local intra-arterial thrombolysis using thrombolytic agents infusing into the artery where the obstruction is. Next will be bypass surgery if there's insufficient flow back or to exclude an occluded popliteal aneurysm. Okay, so this is where you can do, say the popliteal aneurysm is occluded, then you have to do a bypass. If the cause is due to thrombotic disease, the options are local intra-arterial thrombosis. Let's say thrombolytic agents are infused into the artery where the block is. Next will be angioplasty, which can be combined with thrombolysis. Arterial bypass surgery. Intra-arterial thrombolysis is often difficult to conduct within 6 hours. Okay, thrombolysis takes time, so you don't have time, so you may want to do a bypass for these patients. Okay, so therefore bypass surgery is usually often considered for patients with Rutherford A, 2A, where there is time to salvage. And the last one, if everything fails, if the patient comes to you with Rutherford 3, irreversible, with massive damage, tissue damage, then you have to do amputation. And the levels can be at the toes, the foot, below knee, or above knee amputation. So this is considered life-saving for all patients with Rutherford 3. Okay, these are pictures to show you the ischemic changes. Please see a patient here with embolism. The toes are the ones usually start changing in color, becoming ischemic and even necrotic and gangrenous here. Here you see, and then these patients also has got trophic signs. Okay,
hairless, skin is shiny, the toes are tapering, and then you have got your friable toenails here. Okay, this is a ischemic, acute ischemic limb ischemia in a patient with embolism. Okay, this is a arteriogram of the upper limb that come with patient with acute ischemic obstruction in the upper limb who went local thrombolysis. That means you inject thrombolytic agent into the artery where the block is. The block is here. So after your uh, infusion of thrombolytic agents, then you see the limb becomes revascularized. Okay, so this is before thrombolysis. This is after thrombolysis. Now, what is this Fogarty treatment which I was telling you? Schematic diagrams, the use of Fogarty catheter. This Fogarty catheter, I'll show you in a short while, is a catheter with a balloon at the tip here. So what you do is, you push the catheter through this thrombus and to bypass, to go past the thrombus. And then you blow up the balloon and then you pull back and you pull the thrombus out. Okay, this is your thrombus balloon and this is the catheter, and you inflate the balloon and pull out the thrombus. So this is the treatment of acute limb ischemia using a Fogarty catheter. Okay, this is a Fogarty catheter. You see the catheter here. At the end here is a balloon. Okay, so this balloon is deflated. Usually, first is deflated. Okay, these are various sizes of the Fogarty catheter. And then you insert the catheter. This is a thrombus here. You insert the catheter, okay, past the thrombus. After it has gone past the thrombus, and you blow up the balloon. Then, once the balloon is in place, then you pull out the thrombus together with the catheter balloon. Okay, here, this is stenosis with the thrombus here. Catheter goes up, blow up the balloon, and then you pull the thrombus out. So this is your Fogarty embolectomy balloon catheter, the use in embolectomy. And this is done under fluoroscopy. So that means you can visualize the catheter as it passes the obstruction. Now, the last one is your irreversible Fogarty 3. Irreversible ischemia. So this one all irreversible. It's called mortal skin areas of ischemia, and this whole leg becomes the ischemic below the knee onwards. Okay, there's pallor, rubra, and all that. All these ischemic changes that take place here. Mottled, non-blanching appearance with hard woody muscles requires urgent amputation or taking a palliative approach. Most post-operative cases require high level of care, typically at a high dependency unit or ICU. These patients must be, before you go for treatment, must be ICU care must be very important. Because once you amputate this patient, what can happen post-op is your reperfusion syndrome, which can be fatal itself. Okay, here you see just now I showed you massive ischemia. So here you may go for below knee amputation. Okay, here you may have to go for above knee amputations. All right. Okay, long-term management of a patient with acute limb ischemia after treatment. Promoting healthy lifestyle, very important. Regular exercise, smoking cessation, weight loss as necessary. Same as in chronic limb ischemia. These patients, most of them have some degree of chronic limb ischemia. Okay, then you can give them antiplatelet agents, low dose aspirin, okay, such as cardioprin or clopidogrel, antiplatelet agent, or you can give them anticoagulation with oral treatment with warfarin. Okay, this is called the direct oral anticoagulant. Okay, so these patients initially in the ward given heparin and then they're discharged on warfarin. Okay, and these are the direct oral anticoagulant agents. Dabigatran, rivaroxaban, epihexaban, and exoban. The most commonly used is warfarin. Okay. Treat underlying predisposing conditions to the acute limb ischemia. What are the patients? That means heart problems, especially atrial fibrillation. The most common cause of is atrial fibrillation. So, yes, we refer to a cardiologist for further treatment of his cardiac problem. Cases resulting in amputation will require occupational therapy and physiotherapy and long-term rehabilitation. Now, what are the complications of acute limb ischemia? After surgery, for example, once you have removed the clot that causing the obstruction, you reperfuse the limb, you get this so-called reperfusion injury or reperfuse syndrome, they call it, whereby there's a sudden increase in the capillary permeability following reperfusion surgery. Okay, so in the segment where you reperfuse by removing the thrombus, there is a sudden increase in capillary permeability. Okay, and reperfusion syndrome, when the blood flow is restored to the tissues after a period of ischemia. After a few hours of ischemia, you reperfuse. There's suddenly in the reperfused tissues, you have capillary permeability increase. Okay, so in compartment syndrome, following revascularization for acute limb ischemia, fasciotomies are done at the time of the surgery. So when you reperfuse the limb, after that, you also proceed on to do the fasciotomy, so that this will reduce this edema and reperfusion syndrome effects, and thereby reduce the chance of reperfusion syndromes. Okay. Otherwise, the severe calf swelling and severe pain on passive movements of the muscles will lead to very severe reperfusion syndrome. And what happens in reperfusion syndrome? There's a release of substances from the damaged muscle cells, such as potassium ions causing hyperkalemia, hydrogen ions causing acidosis, and myoglobin causing myoglobinuria, resulting in significant acute kidney injury, AKI. So these patients can develop myoglobinuria, leading to acute renal failure as well. Acute limb ischemia has a mortality around 20%. Okay, 30-day mortality rate following the surgical treatment of acute ischemia is 15%. Okay, so there is a significant risk of mortality following an episode of acute limb ischemia. Now, finally, the key points that you must be considered in acute limb ischemia. First, acute limb ischemia is most cases of acute limb ischemia will present with sudden onset of severe pain over the leg, especially the calf, and pallor. The whole limb becomes pale distal to the obstruction, either caused by acute thrombus in situ or embolization. That means a thrombus can develop in situ, or it can come from elsewhere and is acute. CT angiography is the gold standard investigation for these patients, although we normally do a Doppler ultrasound prior to CT angiogram. A variety of treatment options are available, depending on the underlying cause, regional anatomy, and comorbid status of the patient. It is important to monitor for reperfusion syndrome in cases of acute limb ischemia. So that those patients who you reperfuse by surgery or medical means, you must be prepared to and monitor for the development of reperfusion syndrome. Reperfusion syndrome occurs when the blood flow is restored to tissues after a period of ischemia.